So I'm in general. All right, great. So let me just go back to. All right, welcome. This is Dr. Vineet over here. I'm from Singapore. First of all, I want to thank Dr. Nitish for giving us the opportunity to host this webinar on Facebook on his creation Alto. Almost everybody is familiar with Alto. It needs no new introduction, at least to the people in India, and now it's getting world famous. So thank you, Nitish. I would also like to thank the faculty who have taken time, did not say a single no to me at least, and were very forthcoming in making time and coming forth. This is a webinar which is titled COVID, Urology and Me. And I think at this point of time, all these three things matter to us as urologists. I do know that there are plenty of people who did share interest who are non-medical people as well. And even then, I think the presentation is basically talking from the heart. And we are talking about our trials and tribulations of what COVID did to us, not only in the society, our personal and our professional life has been affected, like millions all over the world. And I hope that we share our experiences to motivate you and also to probably give you a feedback of what we really do. So with further this thing, let me start my slideshow. Yesterday I had some. All right, so I know there's a pandemic of webinars as well going on. This webinar, I'm hoping it will not kill you at the end of the presentation. We don't have too much science in it, but we do have a lot of our heart put into the personal experiences that we faced, and we're happy to share that with you over here. And let me introduce, because no meeting is successful without having the best of the faculty, and I'm really happy that we have wonderful faculty with us. Professor Stacey Loeb, she's with us, she's from the US. Professor Darren Smith from UK, and Jeremy Teo, he's a good friend, so I just call him Jeremy. He's from Hong Kong. Daniel is also a good friend, and Daniel is from Spain. Quite a few of you from India know Dr. Deepak Raguri, and Deepak is from Hyderabad, practicing in the south of India. And Professor Cho, the good-looking gentleman from South Korea. I must say, Professor Cho is the only person right now who's involved in some hospital activity, which is also keeping him a bit occupied. He's going to try and be with us throughout the talk, but if there's a necessity for him to leave, then we'll let him finish the presentation. We hope to have this more as a dialogue and interaction, and I'll try and lead you on as we proceed. Let me just say a few words about all the esteemed faculty that we have over here. Dr. Loeb, she's a professor of in Howard, in the School of Medicine in Manhattan. And she's not only very famous for her work in prostate cancer, she's got more than 300 peer-reviewed publications, and I think she's also part of 10 book chapters, which is quite a lot. And she also dons many hats. She's also part of the Men's Health Show, and I think it's in the US and Canada, and I think we're really, very proud of having you on the show over here. And it's not just her. We have more esteemed faculty with us, and that's Professor Darren Smith from the UK. The most important thing with Professor Darren Smith is that he is part of the Boss Chair. And for us who practice endourology, he's coined the term endoluminal endourology, and I think that itself is significant enough. And thank you so much again to be a part of the show. And he has many, many tributes to him, and I probably, if I start, I'll probably finish the whole webinar only telling what are his contributions to the field of urology. Jeremy Teo, he's an adjunct professor. He's with Hong Kong University, and he has really changed the way social media and urology works with the Eurosum group, which he has founded. I'm glad that he gave me a chance to be with him. So welcome, Jeremy. And we have Daniel. Now, the specialty about Daniel is he's from Spain, and Daniel is the most hardworking of us because his bosses grill him. And he being the senior resident over there in Spain, I think they put all the duties on him because they don't want to wear that N95 mask too often. But Daniel, thank you so much for taking the time to come and be with us on this show. Deepak, I think, is extremely fond of endourology. He's in Hyderabad, and as far as I know, he's a very, very proficient surgeon with endourology. He loves social media. He himself started the IREB group, which was trying to connect residents across the world, and quite successful at that. And he introduced me to Twitter. So I should thank you, Deepak, over here, because I think that really gave me a big opening. And from South Korea, Professor Cho, he is one gentleman who most of us know because he's a passionate endourologist. He deals with upper tract cancers. He's fantastic with PCNL, and he's written so many chapters and so many publications. So a very esteemed faculty from different parts of the world. And with that, I would like to just start the presentation by a little tribute to COVID workers. I have friends, personal friends, doctors, and people who've been nurses and other COVID workers who've died. And I would just like to share this. Okay, so that's something. And I'd like to thank Dr. Sadhguru for that. Um, it was just a small tribute, which I felt we probably can thank ourselves, and we can also thank all the people who have been working so hard tirelessly. Uh, so today we are here to discuss these topics. These were the questions which I thought are very pertinent to all of us, especially in our practice. How's COVID affected our country, which has directly impacted our practice? What's been my role? Where do I think this is going? And if there's something which I can tell our viewers. So it's always ladies first. We'll start with Professor Loeb. I'd like you to share with us on how COVID has been in your country and how has it impacted you on your practice. Professor
Well,
Loeb?
thank you very much for the invitation. Certainly, it's had a major impact here in New York City as an epicenter for the pandemic here in the United States. So the city is really shut down. Everything is very quiet. very few cars or people on the streets. The clinics are being held through telemedicine since mid-March, and the mayor banned all elective surgery starting March 15th, and it has not been released as yet. So there's no elective surgery for more than 1 month.
Dr. Lloyd, we've lost you. We can't hear you. Or can you all hear her?
That's really my summary of the impact here. You know, it's also had a significant impact on our research and our education. We're not having any in-person conferences. Everything is completely moved to digital. Luckily, there are a lot of online groups that are having virtual education. So our residents still are getting education, but through these online programs, such as the Empire Lecture Series, which is available online. So what I think is the great thing to come out of this is the fact that there's all these very global educational opportunities that are now being recorded and serving as a repository for urology education around the world, and also just the explosion of telemedicine, which will be great even after all this is over. So thank you for the opportunity.
All right. Thank you so much. And how about Dr. Darren?
Hi and hello everybody, and thank you for the invitation to join you across the world for this. So London, similarly a UK epicenter, and I think we've had much the same situation as our friends and colleagues did in Milan, sort of 2 weeks behind, and I think probably from what we've just heard from Stacey, it's very similar in New York. We had the same, essentially a countrywide lockdown from the middle of March, with all of the same effects on teaching and elective workload. The things I think that might have been different from my personal perspective in London is that the urology hospital of University College Hospital was on a separate site. So it's away from the main hospital and all of the hurly-burly that was inevitably going to happen as more and more of the COVID positive patients came in. And I think from, again, my point of view, and as an endoluminal endourologist, we are very familiar with hand-to-mouth type existent urgent cases coming in, whether that be an obstructing stone or an obstructed kidney because of an oncological cause. So I think we've been well positioned within our hospital and perhaps our unit in particular with managing uncertainty. And one of the lessons that we'll talk about at the end, the extraordinary pace of change, the information that has come in, today's information is out of date this afternoon, let alone tomorrow. And has already been mentioned, the community on Twitter for getting information across and being able to plan ahead. And we owe a debt of thanks and gratitude to Guido Giusti and his colleagues for giving us their own very personal and direct warning, act now, this isn't going to be a small event, prepare and make change. So we've done an enormous amount, and here we are giving a webinar across the world with 8 of us on Zoom. 6 weeks ago, I'd not heard of Zoom. So we've developed huge amounts of expertise, by collaborative work and being flexible. And that's a testament, I think, to the urological community across the world.
Thank you. Thank you very much. If you all have slides to share, then please play them, and you'll have to do a screen share so that we can see them as well. Professor Loeb, would you like to share some slides with us first? Or Dr. Darren?
I've got one for the sort of current state of play downloaded this morning. Let me see if I can do that. That's pushing the skill set. Not stop, share content. Here we go. I can't.
And Dr. Vinit, you have to stop sharing, then only Dr. Darren can share.
Okay, okay. So
You need to
all right.
stop sharing the slide, then he can share.
So I've stopped now. Could you try it, Darren?
I'm trying. No, it still says I can't. It's only one slide. Maybe we continue. And then I'll show it with the state of play when I speak next. How about that?
Sure, sure.
Still, you have not stopped actually, Dr. Vinit. Yeah.
Okay.
Now I think he should be able to.
Would you like to try now? I'm sorry. Maybe
yeah. Okay. Screen.
It just goes to show we may be good urologists, but sometimes technology still beats us.
But we all help each other, and with good humour. Right, so there's your first slide. That was instructions for me what to do. That's what you wanted. The state in the UK today. So downloaded just this morning. So we have, what is that? About 10% of the world's deaths now, 19,000. But it does look like the curve is flattening. One of the things that we will perhaps talk about is, how we mitigate it, the social isolating, the need for testing. So actually, we've got a high proportion of deaths amongst our confirmed cases, and that's because we've not really tested people unless they've been in hospital. So what we're looking at is the tip of the iceberg,
Right.
and the community cases, including in care homes, isn't recorded in that.
Okay.
I'll stop my broadcast.
All right,
Mute myself.
Professor Lloyd, how about you? Would you like to share your slides with us,
Sure.
please?
So this is our case numbers here in the United States as of April 22nd, over 800,000 cases and 46,000 deaths. In New York State, we have had more than 263,000 positive cases, of which 145,000 are in New York City. So that's why we have such a significant impact here. Notably, the number of hospitalizations has started to decrease a bit. So that's some good news perhaps, but unfortunately quite a high death rate, with more than 15,000 deaths in New York State, of which over 11,000 are in New York City.
I mean,
So in terms of our institutional timeline, as I mentioned, we did have a executive order for elective surgery to stop starting on March 15. We, around the same time, suspended all of the local conferences, began telehealth video visits, which we conduct through the Epic electronic health record system using an iPhone or an iPad. And then starting March 29th, all urologists were deployed on a rotational basis to assist with COVID care. There is an update to the surgical policy just a few days ago. This is, by the way, statewide. So I understand, since this is an international presentation, that perhaps I should give a bit more background. But here in the United States, all the decision making and laws regarding healthcare are largely state-based. So, for example, my license is to practice medicine in New York State, and all of the policies do vary state to state. So this is different in other places. However, here in New York, they are starting a gradual reopening. Certain areas, such as Syracuse, New York, up to the north where I grew up, they don't have a lot of COVID cases, and they do have more hospital capacity. So in areas like that, they will be allowed to start elective surgery again on April 28th. However, if there are these very strict criteria, which I listed on the slide, And if at any point the case numbers start to increase and these criteria for the capacity are no longer met, then elective surgery must stop. In addition, all patients must test negative for COVID prior to any kind of elective outpatient surgery. However, none of this applies here. New York City and all the surrounding counties are excluded due to the still very high case numbers in this region. So it remains to be seen when things will be, when or if, I guess, things will be business as normal here again. In terms of the urologist deployment, we've done a variety of tasks around the hospital. Some members of our team have worked in the ICU. Others have served as inpatient hospitalists on non-COVID teams. Others have helped out on inpatient medicine services that are managing COVID. Other urologists have assisted in the emergency department with doing swabs for people coming in from the community. And others still have participated through telehealth. There are some urologists who have comorbid conditions and did not participate in the hospital-based care, still have helped through managing some of the emergency phone lines.
So,
And then finally,
I just wanted to interrupt you here. The interesting point about telehealth services, if I think US was one of the first few countries to legislate it and allow the consultants to charge. Am I correct in that?
One of the first countries to legislate the telehealth?
Yes.
Well, it was very rapidly approved by Medicare during this crisis. So actually, you know, it really was rolled out here very quickly.
I'm just curious whether people are happy about it, or I'm sure as doctors, maybe yes. The management in the hospital definitely, but patients will probably be like, oh, you're going to charge me now, calling me, because Singapore, we haven't yet done that. So I'm just curious, how is it in the US when you call a patient and you finish? It's nice, we have the opportunity to talk to them. But when you finish your conversation, do you say, how do you tell them that you're going to be billed for this?
I mean, ours are billed through insurance the same way that they would have for an office visit. And that's for the video visits where you are actually talking to them over the video. You can even do a limited physical exam, you know, have them press on their abdomen and do a supervised physical exam over the video. Obviously, it's not exactly the same as the in-person, but I think you can get a lot of the information from the video visits, and it is billed to their insurance company and Medicare, and virtually all of the major private insurers are covering this since COVID. There's more spotty coverage for telephone calls. So
do you do video conferencing as well with the patients? Are you allowed to, or can you?
We have to do our video visits through the electronic health record system at our institution. We don't do them through Zoom or other programs, but that is different in different institutions around the United States. I believe at University of California, San Francisco, they do use Zoom for video visits. So some of those policies vary. And I've actually got very good feedback from many patients because at least here in New York City, as you can imagine, we have a lot of surrounding areas like Connecticut, New Jersey, and it could take 2 hours for patients to come into the city. So even on a normal day, many people would love to get to consult with you over video and not have to commute into the city in order to have a discussion. And especially right now, many people are scared to leave their house here because of COVID. So the ability to get to speak to their doctor about issues from the safety of their home is very much appreciated. So I've had a very positive response, and only a few people who really weren't interested and preferred to just delay their visit until COVID quarantine is over.
Because I had I had, of course, like you, most of my patients are more than happy. We called them. I had one interesting gentleman who, he told me, he said, "Who are you to stop me? I'm risking myself, so I definitely want to come over." So we do have patients who at times get a bit aggressive on the phone as well, but most of them really appreciate all the effort that goes in. I'm going to ask Dr. Cho, would you like to share your experience with us?
Yes, okay.
All right, please.
I prepare my slides, so I want to share my slides first.
Sure.
Yes.
South Korea is recovering, and that's been a plus point,
Yes.
which puts you in this fantastic position once you go through to answer the question of when are you going to get back to a normal urology work?
Basically, to begin with, my sincere apologies for not being able to attend this webinar fully because I need to excuse myself because, after this presentation due to a morbidity and probably mortality case.
Oh.
Yeah, with postoperative bleeding after percutaneous nephrolithotomy. So yes, you introduced me just as a specialist for PCNL, but yeah, this is my actually first case in my life, and actually I'm going through one of my toughest times in my life.
That's the worst thing to happen in COVID.
Yes, I performed the ultrasonography, color Doppler ultra puncture, and one-shot puncture was successful, and many things. Everything was perfect, but just I cannot accept this situation. Anyway, thank you for this opportunity. So I want to show the status in Korea. So as of today in Korea, there are, as you see this slides, there about 10,000 cases was confirmed with the daily change around only 10 or 20 cases recently. And total number of tests were approximately 600,000 cases, and the positivity rate was only 1.8%. And 80% of these diagnoses were mass outbreak.
Korea
Yes.
has an interesting drive-through concept of testing. Is that still available for people, or now because the caseload is less, you have to go specifically to centers and only suspected testing, or you still doing community testing?
Yes, actually, there's another. I have another next slide about drive-through and walk-through facility. And I can show you this. I can tell about the screening clinic. Yeah, so there are two types of screening clinics available, as you see the slide, and drive-through and walk-through types. And maybe you already know what the walk-through or drive-through are, right?
No, please share with us. I'm curious. I'm just know that neither drive or walk, but I don't know what happens there.
Yes, drive-through is, yes, you can have a sit inside your car, and the examiners check the nasal swab outside the car, and we just put our arms to check to get some specimen from the patient's nose, and the patients can stay inside their cars. And walk-through is there is a wall, and the examiners stay in one side of the walls, and the patients stay the opposite side of the wall. And there is a glove in the center of this wall, and the examiners just put their arms into the glove, and we can get some specimen in the patient's nose. That we call that walk-through. So for this diagnosed test, there are currently 118 locations, including.
Did you have one too, if I may ask?
Yeah, sure. We have we have, but actually there is a screening clinic just outside the building, and we have the walk-through.
You have one personally yourself for any reason?
Yeah, sure, in my hospital. And since the test facility and diagnostic agents obtained the fast track approval in Korea, and after these two screening clinics, the maximum daily testing capacity now is approximately 20,000 people.
20,000, wow.
Yes. And actually, Since its first diagnosis of COVID-19 in late January to a sudden spike in February 18th, at that time the case number is 31, and there was actually no significant nationwide control. But only after this sudden spike, the government has taken a series of actions summarized in the right side of this slide. Special entry procedure, of course, they except the China. I don't know. I cannot understand that. Anyway, and preventing spread through early detection, epidemiological investigation, and isolation of contacts, and epidemiologic investigation. Interestingly, included the tracking credit cards, mobile phones, as well as CCTVs. Around the patients. A number of new confirmed cases are now quite low. Recently, only 10 or 20 cases a day. Stable, but I'm not sure. It doesn't mean it is well under control anyway.
So the other very nice point in your slide was 95% of your institutes are equipped to screen for COVID, which is great. So that allows your patients to go to the nearest place to get themselves screened.
Yes. We should have many facilities and many special screening clinics to test the patients as far as we can.
Yeah.
Okay, and we have some, this kind of system. So the number of patients in the outpatient clinics and elective surgery didn't show any significant change. And tertiary hospitals in Korea, but the patient visits are downsized by half in small hospitals or in the clinics. So this chart shows the steps and guidelines taken due to COVID-19 outbreak in my hospital. Mm-hmm. So first it shows external individual control, such as patients and visitors. So, and patients must take COVID-19 tests before 48 years of admission and can proceed to operation. And for emergent case, physicians should provide necessary treatment first, but COVID-19 test must be taken as soon as possible.
Do you have CT scans as well, or did you just stick to doing the COVID test? And
not actually in the first place, only COVID-19 test.
Okay.
Nasal swab.
Specifically to ESW procedure as urologist, were you having to do that as well? COVID-19 testing?
No, not actually. If patients have some symptoms, we can send them to the screening clinics. But if they don't have any symptom, then we don't do that.
Okay.
Our patients must wear masks, minimize the contacts, and move within the center. And if any external individuals show COVID-like symptoms, they must take COVID-19 tests. Otherwise, they should wear masks and keep social distancing as mandatory. In terms of medical professionals and staffs, okay, I'm sorry, did I have some, where is it? I'm sorry. Okay. Well, medical professionals. The internal individual control, which this slide shows the internal individual control, and medical professionals must wear some masks, and we must gown up according to the guidelines shows. At all times we must wear masks, and depends on the epidemiological correlation. Staffs, if necessary, their family members as well must take COVID-19 test.
Okay. All right.
This monitor is not so clear, so I'm so sorry. And
we're already having questions, but I'm going to keep the question and answers to the end.
Yes.
Yeah. So go ahead.
Okay. Urology partner members are rotating for screening clinic. So in my hospital, there is a special COVID-19 task force team as a control tower, and they just cascade the guidelines to each department at my hospital. So from April this month, all the meetings, the seminars, our training went online.
Okay. So I think it's about very similar time. The same thing's happening.
Yes, I think we should start earlier than April, but anyway, we started just on April.
Well, you were wearing masks, so I'm hoping everything should be okay.
Yes, but yeah, the recently where is that? Okay, recent COVID. Recently, the government worries about the secondary infection, second wave. Anyway, so as the recent report of government shows, the vaccine may develop next year. Is it right? I'm not sure. Anyway, and they warned about the continuation of this COVID situation for the next 2 years. Last night they reported.
2 years. Interesting. So the government thinks that you are going to be facing waves of people coming back with this for the next 2 years. Is that correct?
Yes, yeah, right. So they are preparing guidelines according to the timeline of 2 years. So
All right. But I'm assuming is Korea back to, would you say, at least 70% normal in its terms of daily activities?
Yeah, but already some of the patients recovered from COVID-19 get the COVID virus again, the second infection. So we are fearful, of the reinfection of COVID virus, and the government has started to talk about everyday quarantine. So it is a set of guidelines about the instructions for how people can resume some degree of economic and social activities while minimizing the risk of a second wave of infection, including visit to library, business meetings, meals at restaurants and shopping trips, theater outings, sporting events, community group, religious gathering, pubs and bars, and so on. So they try to just provide some everyday quarantine to all the people in South Korea.
Interesting. Okay.
Okay, my take-home message is it's too fast. Anyway.
Okay, great. And how about you, Dr. Jeremy? Would you like to share with us Hong Kong, because you guys were the you're the first country outside China which technically faced it there. So would you like to share with us how has it been, your journey so far?
Yeah, sure. Thank you, Finit. Great chance for me to share about my experience in Hong Kong. I prepared a few slides. I think you should be able to see the slides now. Is that right? Okay, so the first thing that I want to share with you all is about Hong Kong. Hong Kong actually has a very unique experience of SARS back 17 years ago. And this is actually the publication from my university, because my hospital is where it began, the outbreak began. And in 2003, globally, there are 8,400 people being infected with SARS, but actually 20% were from Hong Kong. So we really suffered from a big hit during that time. And out of these people, about 300 resulted in mortality. So 17% mortality, and 9 were healthcare workers. And actually one of them is a doctor from China. So 8 healthcare workers who are really local doctors, nurses, or healthcare assistants who got infected and unfortunately passed away during that time. Why I'm sharing this is because it is a very traumatic experience for Hong Kong citizens. And I think because of this, we actually have a very high level of caution. And to a certain extent, it made us perhaps more well prepared. We are much more willing to have protective measures, even at the very beginning of the COVID-19 situation. So since late January, when we had the first case of COVID in Hong Kong, actually for the outpatient clinic, we didn't actively cut down the clinics, but then we had a default rate of about 30 or even 40% although now the default rate is much lower. But then I showed you how our urological surfaces are being affected. So say shockwave, the number of sessions dropped by about 14%, cystoscopy 28%, biopsy almost half. And for the operative theaters, we actually only allow cancer surgeries to continue. So all non-cancer cases are being postponed until further notice. And to a certain extent, on one hand, we are kind of afraid of increased risk of infection, especially during general anesthesia, intubation. There's always a constant worry of aerosol type of viral transmission. On the other hand, in January, late January, there's a surge of usage of protective equipment. So imagine in one general anesthesia case, you have anesthetists, you have some assistants, some healthcare workers helping to move the patient. So one case actually will use a lot of protective equipment as well. So during that time, our administrator already tried to cut down the list quite a lot to prevent an infection, as well as to reduce the use of protective measures. So up to now, the OT list is still quite significantly reduced.
Are you also COVID testing all your patients who come to you?
No, we don't. Of course, we will ask for fever. We'll check the temperature. We'll ask for upper respiratory symptoms, travel history, etc. But if the patient is not having fever, no symptoms, we don't routinely check for COVID. But on the other hand, because I think this is the figure from our government showing the number of COVID cases that we have. The first case came in January, and then for about 1.5 months, the number of cases is just very limited. In March, I think that is when when UK has announced some the stoppage of the schools and universities, and we have a lot of students studying abroad, and that's really when all our students who went to study abroad, they came back to Hong Kong. So you can see there's actually a surge of cases, and the bars in blue, they are imported cases. So you can see a lot of imported cases in March. And then eventually, luckily, the number of cases dropped down till, in April, basically it is back to our baseline. And so for the past week, we have less than 5 cases every day, which is quite okay. If we look, if we look into the figures in March, actually, if we separate it, it might be even clearer. So the line graph in red, these are post-travel imported cases. So it started in early March. And then you can see there is a latency of about perhaps 10 days or so. And then we have a small rise in the local cases. So it seems to be quite in line with what we see with the post-travel cases. So apparently we have more imported cases, and then some local people get infected as well. And then you can see at the top of the figure, we have 1, 2, 3, 4, 5. These are kind of some policies being made by our government. So on the 19th of March, we actually had some regulations saying that people who came from abroad, they would need to have a mandatory 14-day of quarantine. And then number 2, it's basically we had a restriction on the restaurants saying that they need to have a certain distance between tables. They can't have too many people in the restaurants. And then further, we have prohibition of group gathering, entertainment services being stopped, and bars and pubs being stopped, etc. And I think we're quite lucky because with certain policies and I think with a high level of precaution from our citizens, then although we have a small rise in number, but with some time gradually it came down. So both the post-travel and local cases came down. So it's really quite lucky for us, I think.
Yeah, definitely. I think it seems to be going well.
Yeah, and as a citizen in Hong Kong, I think one of the biggest, well, most useful measure is really the use of mask. I told you before, since late January, the first case in Hong Kong, the next day you walk down to the street, actually more than 90% of the people are wearing masks already. And I think this is really because we had such a bad experience 17 years ago. And as you know, I like to do a lot of social media analytics. So I just quickly use Google Trend to see what is the so-called public interest in the different types of protective measures. So I just use a few keywords. The blue one is mask, and then hand washing, hand sanitizer, social distancing. So I think we are doing good in the sense that more people are interested in mask, which peaked in probably late March or even early April. I think that's really when everybody is kind of running out of masks. And so they really try to search hard for masks anywhere, try to source it from somewhere. And if we look into each of the items separately, actually, you can see the interest is masks is actually highest in Hong Kong. We are actually number one in this. And I think this is in line with what I think. Everybody is very careful, very obsessed with masks here. Everybody's trying to buy masks from somewhere, make sure they're stocked at home. And actually, at least from the search volume index, Hong Kong didn't send any place in the other types of measures. So mask is the main thing that we care about here. And but I think it seems that, at least from my perspective,
Sorry, I just interrupted.
Any kinds of mask.
Okay, so cloth mask. Or
yeah, it's. Yeah, so this is just a very simple tool. I just use the word mask, which, you know, any mask basically will be included in this search volume index. Of course, I think this is just a crude measure of so-called public interest, but I think this is in line with what I'm seeing here in Hong Kong. So basically, you walk down the street, everybody is wearing a mask. And I think it's a good thing. I think it really helps. So my last slide here, personal comments, very biased. I think COVID does affect our delivery of urological services. Luckily, we seem to be doing okay. For the past week, we just have less than 5 cases every day, which is a good thing.
Are you back to all, even as you say this slide and as you show us this slide, do you guys ramp up your work slowly per week, coming back to some sort of normalcy?
Actually, not yet. I think it's still similar. Like surgery, we're just doing cancer surgery right now. I think for outpatient clinic, the default rate is lower, definitely. But for the other type of sessions are more or less similar. But since we are having just, you know, few cases in the past week, I think the administrator is planning to resume some work gradually. But probably we'll just go for, you know, a very slow pace on this. But anyway, from our experience, I think a high level of caution, very important. We definitely try to stay home, and we always wear a mask when we go out. And in my personal opinion, I think that really helps a lot.
Sure. I think, if I remember right, a month ago you told me, why isn't Singapore wearing masks? And I said, I hope so. But then, yeah, I think the wearing a mask is quite an important point. So Daniel, would you like to share with us, because your country has been another country which has been unfortunately badly hit. Share with us your experience so far. How has it affected you? How is it affecting work?
Sure. Can you see my screen?
Yes, we can. At least I can.
All right. Hello, everyone. Well, here I'm going to share a few numbers that I gathered from the current situation. So currently in Spain, we have more than 200,000 cases diagnosed and almost 3,000 in the last 24 hours. So even when you see the daily new cases in green in this bar, I gathered this graphic from yesterday. So the curve is going down and it's flattening, but we have still a lot of new cases every day. So it's not a victory yet. We have more than 22,000 deaths and more than 300 in the last 24 hours. So well, things are getting better over here, but not we're not winning that battle yet. So let's see what's coming. I gathered this graphic, so I think it's this bar is quite illustrative that most of the countries that we have here have an elder population. So Spain has a life expectancy of 83 years. Italy, that was hit very hard also, 83 years. Singapore and Hong Kong that we have here. So that's an important point, because most of the people that have died from this disease in Spain, it's elder population, you know, more than 70 years. And this is the distribution of ages in Spain. So we have an elder population and we have a lot of elder and frail people, and that influences a lot in how many people die. So how are things in my hospital right now? The good thing is that we have, even if the ICU is still full, we have few cases ventilated and in the adapted ICUs. And by this, I mean, the normal ICUs are still full of patients. We adapted a few areas like operative rooms or other areas with ventilators for patients that did when the ICUs were full. So these areas are almost, sorry?
No, I'm sorry. I'm just going to interrupt you in between. I want to make this a conversation. That's why. When you say adapted ICUs, you mean these ICUs where part of the ICU adapted to become COVID specific, or?
Yes, exactly. So if you have an ICU with 30 beds and you need more ICUs, well, the government were buying more ventilators and they adapted the ORs, or they adapted a few areas to ventilate COVID patients. So not an ICU per se, but ICU adapted for some sort. So these areas are being emptied right now, are being cleaned. The hospital is some sort of coming back to normal. Urologists are no longer helping in COVID areas. There were about 2-3 weeks that urologists helped in the emergency department. We were helping in COVID hospitalized patients. We were helping in administrative stuff to release the pneumologists, the ICU personnel to see more patients, and we were helping with administrative stuff. So we're no longer helping. They don't need our help anymore.
Why is that? Well, why
this is because there are quite a few cases, new cases daily that need hospitalization. So even if we have a lot of new diagnoses, there are not much hospitalizations. So the hospital is, the hospital is getting less patients also hospitalized, and they don't need our help anymore. So that's quite good.
Where do they go once they're diagnosed with COVID? They don't come to the hospital. So do you quarantine them or isolate them in specific areas?
They are just told to isolate at home, which I don't know if that's very effective, but considering that patients are infected a few days before getting symptoms, probably their family members are already infected, you know. So, well, they are being isolated at home. At the beginning, they tried to isolate them somewhere else, but it's impossible. There's not enough room.
I know from you as well that when you had to jump into all this help that they needed from all doctors, did you have to go through some training for ICU? My biggest worry was, I won't be able to intubate. I'll only be able to catheterize, and I may not be better than that in an ICU. But so did you have to go through training? Or just jumped into it and learned as you went daily, because it was overwhelming in Spain a month ago?
Yes, well, in my hospital, thankfully, we did not have to help in such critical areas. We did not go into the ICU directly. We did not need to intubate or manage a ventilator or anything similar. We helped managing like the 30-year-old female with a little bit of dyspnea in the emergency department that has a normal chest x-ray. Well, that patient could be seen by a urologist, but anything that was a little bit more important was seen by a clinical doctor, not surgical.
Okay.
So far, we don't have any scheduled surgery. Very few selected oncological cases are being operated on, but we have to share those slots with general surgery, with ORL, with OB-GYN, with all the specialties. So we have 4 ORs, more or less, working every day. So very few cases are being operated. We as urology service, we're doing like 2 or 3 surgeries every week. So since March 23, more than 1 month, all scheduled surgeries are being shut down. And well, our role here is again, we helped in COVID hospitalization. We gave support in emergency department in non-complex cases. And we gave support in post-hospitalization units. So what does it mean, post-hospitalization units? So, well, I guess other countries made something similar. This is the IFEMA, which is a meeting congress or meeting building, which is huge. They adapted it and put 1,500 beds inside. These were all post-hospitalization patients. So this means these patients cannot go home because they're not well enough, but they don't need ventilation. They don't need any chest x-ray. They might need a few IV medications. They might need a few oxygen, but they're getting better with their disease. So those patients were translated to, were taken to the IFEMA. We also made something called medicalized. I don't know if there's a word for that, but medicalized hotels. That 40 hotels in Madrid were adapted with more than 9,000 beds to take patients there for similar purpose. If they need a little bit of oxygen, they need a little bit of medication, and they were not considered well enough to be at home, but not bad enough to be in the hospital.
So you have enough nursing staff, because you take away nursing staff from the hospital to go for medicalized hotels and all this, or do people volunteer to get sort of help out with this? I'm not too sure if that's even a good idea, but
yeah, well, some personnel was volunteer, but the government also made a lot of changes in the legislation. So if you are a nurse that studied in the UK and you came to Spain, the usual stuff is that you have to regulate your diploma and see if you can work in Spain and where was your education or anything. So before you could work, you have to go through several steps. And the government said, like, there's no rules now. Everyone that can work will work. So
okay.
They hired a lot of nurses, a lot of physicians, all medical students that recently graduated. They could work instantly. Of course, they were not given any critical role in this, but they could see patients, they could help, and there was a lot of staff. Military doctors that usually do not work in this sort of stuff were also helping. So yes, a lot of staff was hired, and this, the IFEMA in fact is being closed right now. So
okay.
All these more than 1,000 beds are gone. Well, not gone, but they have no patients.
All right.
Well, this is just a short timeline. In March 14, so very similar to UK and the United States, we had the lockdown announced. probably at May 9th will be the lockdown lifted. That's the
Let's give
approximation.
fingers crossed. Yeah.
It's they keep moving the date, so we don't know. But so far, it will be in May 9th. The lockdown will be lifted. Some
Okay.
sort. So, what do we think is going to be next? So, several months of social distancing, just like everyone else has said. Probably this will be the new normal. Home office will be still the rule. Everyone that can do home office will remain at home office, and there will be limited outside activity. I don't think there will be any bar or stadium or anything similar open. So, well, maybe in 2021.
You have a bar at home, I assume.
Sorry?
You have a bar at home, I assume.
Yeah. so well, the hospital right now is developing these clean and contaminated pathways. We're cleaning some areas, like for example, our urology floor with 60 beds was completely filled with COVID patients, and right now it is being cleaned to start putting patients that are non-COVID. So we're starting to gradually move to normal activity. Maybe
when you say clean, you mean physically cleaning, decontamination?
Yes.
So
exactly.
How is it going to be done every day for a week or 10 days before they are ready, or how are they?
I cannot tell you the protocol they're using. We were just said that these areas are being decontaminated, so non-COVID patients can go in. So a lot of floors of the hospital are being cleaned right now. So even if I don't see the patients directly, this tells us that the hospital is getting emptied. So even if the ICUs are still full, so well, non-critical patients are going home. And well, that's it. Maybe I can leave my personal advice for the end, or I don't know.
Yes, we'll come back to the personal advices in the end. So Deepak, can you hear me? I think you're still muted.
Yeah,
Deepak.
I can hear you. Can hear me?
Yeah. So the reason we kept you till the not to the end, but then to come now in, because India is the last in the line, which is unfortunately not to be spared, but still managing very well. Tell us, how's it been for you?
Yeah. Yes, I'll just run through a few slides I've made. And yeah, I hope you can see the slides.
Yes, we can.
So, yeah, like you just said, and before that, thanks for having me on this panel with colleagues from all over the world. So if I have to say, where are we as far as India is concerned, I guess to the west of us, the impact is quite severe and it's ongoing. And to the east of us, they've gone through their worst and I guess they're on their recovery path. So we are bang in the center, maybe at the crossroads. So if you have to ask me on where the country stands right now, I would say a country like India with 1.38 billion people, which is like 1/3 the size of United States of America, and the kind of ethnic diversity we have and the language barriers in terms of multiple languages across socioeconomic challenges, like you all know we do have, and the literacy, which is also kind of challenging for us. And the healthcare infrastructure, of course, is I might say, still wanting, and the hygiene standards being subnormal. It's a humongous task for India if we have to go through a rough patch like the West is going through now. And this map here depicts like how within a country we have multiple countries within us. So that's the kind of complexity we are facing. And what is it the government is doing? Like, if you have to ask the government response, starting from January 12th, when WHO confirmed about the novel coronavirus. And India began its thermal screening at its airports to start with 7 international airports and then slowly progressed to around 20 of them. That's around January 20th. And come 30th, we reported a first case in the city of Thrissur, that's down south in Kerala. And then the screening slowly started progressing all over the country. But the questions were always there. The asymptomatic carriers, no comprehensive nationwide surveillance, inadequate testing, it's still a question, and minimal public awareness. These were a few challenges which were always there and creeping up. But then the second case and the third case came around this February 2nd and 3rd. These are also in Kerala. And all these 3 guys were students who came back from Wuhan. So that's how it started, the straight link to Wuhan. The first 3 cases were all students, and nothing happened for almost 1 full month. So it's only on March 2nd that another couple of cases were diagnosed in our capital city of Delhi. And on March 4th, 22 cases, predominantly Italian tourists who were there in Jaipur and Delhi, they were diagnosed with COVID again. So that was a major set of patients where we started having COVID. And then, of course, in due course, the Epidemic Diseases Act was evoked, which was like in 1897, which was actually implemented in the British rule. And of course, the entire health sector went under the central government's control from then on. So March 22nd is when the central government, the Prime Minister of our country, asked for a 14-hour voluntary public curfew. It was strange to hear, though. A lot of us was like, what is this for 14 hours? And then slowly, by the time, and the next day, very next day, the government came out with the rule saying that the lockdown will be extended to the 75 districts where the COVID cases were positive. And in no time, that is when the cases were around 519, this was on March 22nd, with a kind of critical care beds per capita, if you have to look, it's kind of the lowest among those countries which you see in the graph, which are like going through a very stiff challenge now. And also the public being very skeptical about the response of how the isolation and restrictions would actually help. 61% of the Indians believed it's not going to help much. In spite of all this, we went into a lockdown on 24th of March. And a lockdown of a massive scale of 1.3 billion people were locked down. I guess it is an unprecedented scenario anywhere in the world. And it's been termed as the largest lockdown ever in mankind. It's no mean feat for the kind of challenges we have in India. And look at the numbers below us. It's just no comparisons with the kind of issues we have. But if you have to look at the numbers and look at the graph, from March 22nd onwards, it's been slowly and steadily picking up in numbers. We're around 25,000 now, around 1,400 cases per day, but it's still okay for the kind of population we have. But if you look at the cases per million, I mean, the death rate is quite low. We are right up there as far as the death rate per million is concerned. And as far as tests are concerned, we are quite inadequate on that. Slowly picking up. We have reached around 550,000 as of today. And if you have to look at in terms of tests per 1,000 people, Italy is up there with 27.7 if the fraction matters at all. Whereas India is concerned, we're abysmally low. Basically, it's like 1 in 3,000 are able to be tested. Having said that, the positivity of these rates, if you have to do 100 tests, they are around 4.4 is the positive rate. So we have both pluses and minuses in the way things are going forward. But the confirmation rate, if you look at, it's quite low. It's around.
How easy is it, Deepak, to go and get yourself COVID tested in India? Because you can just walk into any hospital, like in Korea, 95% hospitals are well equipped. Is it similar there in India as well?
No, it's not so. It's not so in India because the number of test kits that are available are kind of very less. So it's not for everybody unless you are a suspected COVID with predominant symptoms. Only then you're qualified for it. Otherwise, you can't get your tests done. And again, within the country, each state has got its own set of rules. And the place where I am in the state of Telangana, only the government sector hospitals are holding these kits, and you can't do it in private sector. So if anyone is of suspicious symptoms, they are referred to the public health and they take care of it. And amidst all these, we're still under lockdown, by the way. It's up to May 3rd, and we hope things will be fine. And as of today, pre-lockdown and the post-lockdown positivity rate is quite encouraging. It was 21%, and now we are around 6%. So that's still good news. So we are still had to cut down. As of now, the numbers are this. It's around 24,000 and change. The deaths are around 780. So I wouldn't say it's bad, but we're just...
Will numbers justify the lockdown being extended as well? Do you think it's directly attributable, in your opinion, that the lockdown keeps people away, social distancing is enforced, and that's why you're doing so well?
Yes, that's the main factor as far as India is concerned, for the kind of population, the kind of challenges we have with social distancing. The best solution for us is to just stay put at home, stay home. There's no other way we can contain things in India. So that's as far as COVID situation in India is concerned. I'll go it back to you, Dr. Vinit, and I'll just take the other questions later.
Just Yeah, so Deepak, your hospital is also designated to be ready for COVID in case. You mentioned that to me a while ago. Just curious to know whether your hospital had to go through different, like in Spain, they had to get things ready. Is your hospital ready too for
Okay.
that?
Now that you asked me that question, I'll answer that as well. So if you
Okay.
look at the impact of COVID on my institute, I practice at a private health sector unit like Asian Institute of Nephrology and Urology. It's a single specialty center. We do just urology and nephrology and nothing else. We are a 100-bedded single specialty tertiary care center. And we have stopped all our OPD services. There are no elective surgeries like all of you have been saying so. Of course, there's no transplant program going on, and we are not designated COVID hospital. Although we have been listed on the second, what you call options, wherein the government needs isolation beds way and beyond the beds available from the government sector, then we come in. Yes, we are listed, but we are not a designated COVID hospital as yet. So I was just mentioning about various states having their own rules within the country. And this is the state which I live in, with Telangana, where there are 5 government notified hospitals which have around 3,000 beds. And I'm happy to say that we are fine with that. We are around 780 cases as of now. So with a lot many beds available for isolation. And the second option would be the medical college hospitals, which are around good to 7,000 to 8,000 beds. So the private sector hospitals are quite far away from getting the COVID positive patients. And all the positive patients are supposed to be dealt with the government sector. The private sector has got no role, and it's by rule that we are supposed to send them to a government sector to deal with.
Because India's unique position is that you have private hospitals, the nursing homes, as they call them, which are smaller bedded, 10 to 12 bedded. So it's a bigger challenge in the medical health,
Yeah.
medical sector there.
Yeah, very true. When you compare it to the rest of the world, where the public health sector plays a larger role or the main domain, it's converse in India otherwise. Majority of the times, the private sector is the one which is leading the show. But with all due respect, the government has taken very wonderful steps this time around. They have taken the entire show into their hands, and we're just following the orders the government has to do. Yeah, it's a good decision, by the way.
Great. So I think we'll go back to UK and Dr. Darren. Why don't you tell us what's been happening with you in your hospital? And we can share notes with Professor Loeb, because UK and US are right now maybe the current hotspots, not excluding Singapore as well. Dr. Darren, can you hear me?
Yeah, I've got it.
All right.
I'll put my screen on and try to be brief and punchy. So, I mean, I think our situation is a mixture, a melange of all of the things that we've heard so far, and goes back really to what we all kind of said right at the very beginning: the pace of change, the challenges of things, the keeping up with information. So, like we've just heard about being in a off-site, non-acute hospital, the urology part of my hospital, UCH, was on a separate site. So we have continued to do urgent elective work there, which is mostly oncological, but includes the things that an endoluminal endourologist does, including patients with stones in ureters and obstructed kidneys to support the oncology service. There was a question whilst we were talking about how do we do emergency case management. If I flick through some of these slides, in fact, this one is quite useful in that everything other than an obstructed infected kidney is urgent elective. Patients with abnormal renal function, if you're concerned that they've got a stent, of course, it's inconvenient. Even if the patient comes in with acute colic and has got pain, these aren't actually emergencies. And one of the things that we found very early on was creating these sorts of guides for prioritization is actually quite difficult, not least because everybody's got a slightly different view. But more than that, we all had much less access into the operating theatre. And how do you prioritize within this priority list? Whereas the genuine emergency that arrives in your A&E department or your ER, ED, wherever you are in the world, that's kind of predictable at a general low rate that we can manage, has an assessment, and then gets admitted or not. In fact, we've also seen that the amount of non-COVID work has reduced substantially because people don't want to be coming into the hospital. And on this particular point, our challenge is that our main site, where any of the emergency work would be, because we're trying to keep our own site as COVID negative, we wouldn't be able to do the full range of things that we would ordinarily do. So in a patient with acute colic, for example, who had unrelenting pain and needed disobstructing, we'd have just put in a stent and kept it quick and easy and have the patient sent home, rather than try to do a primary ureteroscopy. I think,
as the boss chairman, how easy or how difficult was this decision taking for you? Because a lot of people were looking at you, and we are very happy that you came out with these guidelines, because it was easy for us to adapt or to consider.
Well, there was sort of a degree of serendipity in it, as there always is. So there was a bit of fever in my house, not me. I've been ludicrously well throughout, and I had to then self-isolate. At the time I said self-isolate by proxy, so that people weren't worried about me directly. And had a call from Tim O'Brien, who's our next president of BAUS, saying, well, that's a stroke of luck. You're at home, this is needed. Why don't you just do it? So I made the series of slides that I did. I'll skip through those. My role. So then on our national website, we thought, well, it's all well and good putting a whole load of priorities in for us as urologists, but there's going to be an absolutely vast number of questions and queries from patients. So just like we've heard from the Spanish situation, a whole load of red tape. Nurses come in, they need to go through a special board, sign this, do that, fill out this piece of paperwork. This was exceptional times and needed a rapid response. So this bit of patient information that we put up on here with the frequently asked questions that you can see below was basically all done in 24 hours.
Wow.
The patient information leaflets that we had created some years ago, which I think a few people around the world use, took us about 18 months. And at the same time that we were doing this was our contribution. Our main hospital, closed all of the theatres to make them available as ITU beds, closed wards, stopped all of the other surgeons doing their elective work in that hospital, so that we created a change in our ITU footprint from 50 beds to 250 beds, and therefore we've had a bit of capacity. And the flip side of that is that all of those surgeons and their work has come out of the main hospital, part of it in ours. So we've got gynae oncology in ours. We were going to have colorectal, but in fact, like we've just heard in the Indian situation from Deepak, the private hospitals have been subsumed by public healthcare via the NHS and are all being used for the urgent oncological work. So colorectal is in one of them. They've got breast management in another, with then people across the different NHS organisations working together, sort of like in super centres that are off-site and hopefully still COVID negative.
Right. You skipped some slides. Please share those with us. I mean, the boss thing was just exciting, so I just led you there. But I'm sure you had a lot more to do as a urologist in your centre as well, apart from being in proxy at home.
Well, yeah, fortunately, so that didn't last very long because the advice got changed, and because I was asymptomatic, there was still this was about the first week in, so the second half of March, and we've now introduced more testing, so we're testing patients preoperatively, like we've just heard. So I put together these slides. I think, I mean, they're out of date already, but they won't be unuseful in that these categories of patients will be useful when we begin the discussions about getting the work back in, when the social distancing, isolation, the curve has been flattened, and we have to prioritise the urgent work the non-COVID surge, if you like. All of the patients that we would ordinarily have expected to have seen and be treating, those ones, and keeping tabs on those. That's also quite a challenge. I think maybe I'll just stop on that now, Vineet, do you think, and we'll hear the New York perspective on those things from Stacey.
Yes, please.
Okay. Thank you. So for the New York perspective, my activities is basically, can you all see my slides?
Yes, we can.
Okay, so I did some shifts on the inpatient medicine team, helping them with the management of COVID patients. I had to learn how to be a medicine intern, so it was a very interesting role after having been what you would call a consultant in a subspecialty field for many years. So really going back to basics, like looking at an EKG, which isn't really something that we do a lot of in urology, or especially localized prostate cancer. Other than those shifts, I've been doing urology practice only through telehealth. Absolutely zero in-person urological activities in the past month. Have not set foot in the urology space, and I actually have not seen any of my urology colleagues either, since they were deployed in different areas of our 3 hospitals, and we have not been hosting many in-person activities. So the telehealth has been going great, as I mentioned, and we will probably resume in May with some much more limited in-person activities. So at that time, patients may be able to start coming in for, PSA tests or other things like that on a limited basis. Otherwise, also performing remote research activities. Our institution has a ban on all human subjects research that's not COVID related for the most part. So all of our human subjects research has had to wait until it's safe for us to be able to conduct these activities in person. But it has luckily been possible to still work on some of our digital health initiatives and international collaborations that do not involve in-person visits. And then just joining in with some of these nice education activities, such as this webinar today, and also some of these initiatives here in New York. For anyone who has not heard about this, anyone is welcome to join in the Empire Urology Lecture Series. So lots of great lectures going on that are available daily on Zoom. So please feel free to join us.
Yep, that's pretty, I'm sure the Empire Urology series is well advertised, and a lot of people are looking forward to that. Would you like to share something else, Darren? I'm just keeping the Singapore experience to the end. It's been exciting to hear everybody.
I'll do start. I'll do the few bits for the future as we've heard.
Sure.
And again, what's definitely happened with electronic communicating, whether that be with patients or with colleagues across the world has got a lot smaller, and that's done it very quickly, and it has become a lot more collaborative. Again, 6 weeks ago, we would just never have considered the idea of somebody sitting in London might dial into the New York plenary lecture series, or the discussion that we had with the EDGE Consortium a couple of nights ago about listening to 3 American colleagues and 1 Londoner talk about asymptomatic stones. I mean, it just wouldn't have happened, and that's really something that we must continue in the future. So for London, lockdown, and the UK lockdown review is being reviewed in the middle of May. In the meantime, I think we all need more testing. We are doing these 48 hours before the patient comes into the hospital. Everything we're learning very quickly, so that's what to do with the results. This is important because my list, and actually I still have a theatre on a Monday. I've got three patients to operate on with urgent conditions this Monday, and they will be in our hospital having their swabs today. So this morning, in fact, so the results will come back sometime on Sunday afternoon, and that makes it slightly challenging to manage a list. We're used to that sort of uncertainty in normal times. You know, the patient passes their stone; they don't need an operation here. With that, that's familiar. The problem now is that the resource of theatre is even more valuable than it was before. And what do you do with those results if it comes back positive? Of course, you're not going to be able to find another patient for Monday morning. If you extend the testing interval, then of course you don't know whether the patient is going to pick up the coronavirus in the interim. So I would agree completely that we need to maintain the social distancing to minimise that and have less of the disease prevalent in the community. And then, as I've put there and mentioned previously, you know, we are going to have to start thinking, and if we're not doing it already, then probably we should be, when we can reintroduce our theatres, which patients are going to go first, how are we going to get those back in. And one of the things that is a force for good and positivity is perhaps for us as stone surgeons, a resurgence of shockwave lithotripsy, particularly for ureteric colic. We'd heard last year in the NICE guidelines that we should be doing more of it. And as you can see in the top left on the picture, long-standing mate of mine who I've known for about 20 years, Steve Gordon, pinged this message and said, maybe we should be doing more of it. And perhaps because of people being at home, these things get picked up and grabbed. On the right-hand side is the Bausender Urology Committee. So we're going to try to provide this as a referral service for the centres who've still got enough staff and a fixed site lithotrip to offer a sort of transfer, treat and send back service for patients with acute ureteric colic. Gets them treated now and means that they won't be a patient who has to go through the post-COVID surge and have a delayed ureteroscopy. Take-home messages. So everybody is doing more things that are different. I did a shift on our ITU doing the turning of patients for proning. Teamwork was always important, and now it's essential. And the new currency is not cash, it's kindness. We've all been used to being flexible in our work, or thought that we were, but I think this has shown whole new levels of flexibility, including hearing just from Stacey there that she worked in A&E departments, and those people who are managing patients with respiratory symptoms, or even trying to examine somebody using an iPad at home. What I've put there on the blank sheet thinking is that we've also got used to the idea of solving problems by working around them. And I think that this is a really great start, a great fresh start. So instead of solving problems and not getting rid of the problem itself, imagine that we've got that blank sheet of paper, and really what does our perfect urological practice look like? We've got a little bit of time to think about it. And when we get to the time of reintroducing our work, it should look like the perfect solution on the blank sheet of paper, and not what we were doing previously.
Absolutely agree with that.
So I'll stop those there.
All right, Deepak, we cut you off a little bit, and I think you were trying to share your slides. I'm sorry on that.
Yeah.
Can I get back to you before I start?
No, no, no. I'll quickly go through the remaining slides so that you can finish off your presentation as well. So I think I'll quickly go through what my role in COVID. Like I was just saying, we were not a notified COVID hospital as such. So I would say I had a very limited experience with the COVID patients per se. But we do have had a few suspicious patients where primarily they were renal stones or ureteric stones overlapping with sepsis and fever and cough. Obviously, every fever and cough these days puts you in a spot of bother. But luckily, none of those patients have tested positive. And we've made a CT chest screening mandatory to patients who are getting admitted on an emergency basis. So that's one of the changes we have made to our daily practice. And we've not dealt with any positive patients in our hospital setup as of now till date. And of course, the necessary precautions and the personal protective equipment, which it's been suggested all over. And we've been short of those. And so we had to do our own innovations as to how we deal with that. And I was also involved in doing protocols for various departments as to how we would have to handle this when it is going to arrive at our doorstep. And I'm also a part of team which is managing human resources at the hospital. So we're just planning as to staggered way of using them. Not all of us are in the hospital at one point of time. And of course, some few pep talks to the employees to keep their spirit up, although they're not facing the COVID positive patients here. Like I was just saying, a few innovations we did our own PPEs. These are the ones which are tailor-made by our own tailor. In fact, a cotton with a more amount of polyester in it, so it gives some sort of protection. With the visor, which is also made by our nursing staff.
So can I say this is homemade in your hospital?
Yes, everything nurses are wearing is made by us. So it's something we had to do ourselves because of the shortage of PPEs, and it gives a lot of confidence to our girls who are there working day in and out. So these are all, the visor is made of just a few rubber bands and an OHP sheet, which is a plastic one which is cut. And the one at the head visor is just a pad with cotton in it, so it just absorbs the sweat. It's a simple remedy. It costs you 5 rupees. That's nothing. And a few changes in the OR as well, where we just use an L angle over the OT table to just have a plastic sheet covered over for those few patients who have to intubate, cut down on aerosolization. So we're just doing our own part of innovations there. But if you ask me, where are we headed? And of course, this is not going to go anywhere, not to go off anywhere soon. So how India exits its lockdown is going to be a huge challenge for us. And that's a big question mark. But as far as the preparedness is concerned, around 600 COVID hospitals, control, around 220 laboratories. There are over 100,000. It's growing by the day, the isolation beds, and around 25,000 ICU beds. Thank God, as of now, they're not put to its full use. And around 40,000 ventilators around the country, which is nothing actually for the kind of population we have. But we're slowly getting there. We're able to add maybe another 50,000 ventilators very soon. And all the government sectors are pitching in to do their bit. The Indian Railways have come out with low-cost ventilators, which are really a fantastic innovation. And IIT, the Institute of Indian Technology, is also coming out with new ideas. And you look at this, all our Indian railway coaches have been converted into isolation wards, if need be. See, so that's an innovation from the Indian Railways. It's a massive network of rail in India. So we're using all our coaches for isolation. So close to 2,500 rail coaches being used for this. And of course, if not much, the Kerala government is also using its boats for isolation of people. And a great gesture from the 5-star hotels in India. The Taj Group is actually using all its beds in Mumbai to host the doctors in there, all the nurses or doctors, the medical healthcare workers, who are also victims of, the society getting angry at them. A few of them are actually revolting against them. But yes, the hospitality sector is pitching up there to host all the doctors into the 5-star hotels. So it's very nice to see the society coming in, pitching in and doing its own part. And as far as innovations are concerned, this is another advanced mask that it's just come out last week from the Central Salt and Marine Chemicals Research Institute, where they have come out with a membrane technology in the mask, which actually kills bacteria, virus, or even fungus, in fact. It's got an outer porous layer, which is modified polycell foam. It's 150 nanometers thick, and it can kill virus, which is 60 nanometers and above. And when I say that, we're dealing with a COVID virus, which is at 80 to 120 nanometers. So it's very well effective for it. And they claim to be superior than the N95s. It's in the process of getting an approval from the Indian Medical Research Council. And it's supposed to be costing you less than $50. It's maybe 50 cents, if I have to say. And it's supposed to be usable. So there's another promising innovation that's come from India. And of course, I guess majority of the countries are coming out with innovative apps to do primarily the contact tracing, and the Indian government has also come out with one. Although as of now, around 70 million people have already registered onto it, but for a country with 1.3 billion people, it's a small number still, but yes, we have made a start. And we all know, I'll not talk much about the vaccines that are going to come, when are they going to come, but there's a lot of activity happening all around the world. So let's hope for it to be coming soon. And
Yep. We'll come back to your take-home messages later in the end.
okay, fine. Right.
Okay, so I'm going to try and come back to, it's been fabulous. I think a lot of it is what we are doing in Singapore too. But I'm just going to try and, sorry, we went back to that, excuse me. Share with you what we are doing here. And I think what's unique in Singapore is that we faced what I call as a four-phase. We started off with hardly any cases. Then we brought back our people back from other parts of the world. And then the students came in, and then there were cases again. And that curve was still manageable all the way till April. But April, ever since the foreign workers living in the dormitories have got affected, that's been shooting up the levels. The only good thing about that is they are young, and maybe their immunities are stronger. So we aren't hospitalizing too many. Just like in Spain, we are isolating them. Very similar photographs of places which are being built. Hotels have been employed, and government's doing a lot of effort to isolate and quarantine people. We have here what we call as DOS1 levels, which is just basically to inform how things are. We are on DOS1 orange in Singapore, but we are sort of in between orange and red. It's only because there was a big spurt in the last 2 weeks, but we are still at orange. So I would say that we have good social distancing, but we still have some activity which allows us liberty to go and pick up things we need from the malls, unlike India, which is totally in the lockdown. So the other thing that it's made headlines is because we call it the circuit breaker. And circuit breaker is a unique term. I think it does what any circuit breaker in the house is supposed to do. We're trying to break the virus infection. Will it work? And in Singapore, very often we use can or cannot, and I think it can, and it will. It's just that we've had to extend the circuit breaker for a slightly longer time for very similar issues like that in the rest of the world. I'm going to play this video. It's a very special friend who's also the head of the department. This was the first hospital, and I'm passing it on to Dr. Sharon.
Dr. Vinit, I guess you should share your screen.
Oh, okay. That's always a problem. Hold on, yeah. I am actually sharing my screen here, funnily. You're not able to see it?
No, we're able to see you. Yes, now there
Okay, you can? Okay.
Yes, now.
So anyway, what I spoke, I'm not going to go for that, but I'll continue from here. So this is Dr. Sharon Yeo. She's the head of Tan Tock Seng Hospital, and she was the first very inspiring lady. She jumped into COVID management as a urologist and set things with us.
Dr. Vinit?
Yes, please.
Your this video voice is not there.
Is it?
Yes,
Okay.
I think you have to allow your computer to share the microphone of the video or something. Some setting change you have to do.
On Facebook you're not able to hear it? Is it so?
Yes, I don't know. I'm not able to hear. What about others?
I can't hear. I couldn't hear the other one actually, but the pictures were powerful.
But you
Or
can't.
else you can give a running commentary. What's he speaking? I think probably.
Okay. All right. So I'm going to voice this thing.
And change the
So
setting.
this is Tan Tock Seng Hospital. This is Dr. Sharon Yeo. They have 1,700 beds at their hospital, and they're connected to the National Center of Infectious Diseases. Now, the reason it becomes so important is because even we in Singapore, from the SARS experience, have to understand exactly how to tackle this problem. And we've had some experience before, just like Hong Kong, and it's actually given us an understanding. So the minute the first virus hit us, we actually got into action over here. So what happened is she took the lead and she actually implemented changes in her hospital, which is basically all the changes that y'all have spoken about, where we cut down workload, all the urologists were moved to work. This is a video on this side, which is basically the the Infectious Disease Center. And this is just to show you practically what all goes through. So the doctors over there, actually, once the first case got confirmed, we're all moved to take up shifts over there. And we had to all do what most of you have to do, apart from sharing our responsibilities as a urology department as well. We cut down all our work when it came to residency training, elective surgeries, outpatient work. But we didn't have to do this in most of March, except for her hospital, because that was the first hospital which had to jump into this. It's only by the second half of March, when the caseload moved up, we all jumped in and we all had to do very similar things what all of you have shared. It's not easy for a urologist to do all that, but then we are doing it over here. Unlike Spain, we are still expected. It's all voluntary work, but all the doctors from different branches are doing all that's required to do just with COVID. Our hospital's workload as well has come down to maybe 30%, excuse me, just about 30%. And that's actually allowing us to focus mainly on COVID work. So, in this center over here, it's just open 24/7. This is the main place where people come down if they are COVID positive. But some of the hospitals, like our hospital too, they come over. But what goes on here is exactly what goes on even in our hospital. So I'm going to let that video just play by. She's explaining the various steps. She's explaining the various steps which we have done. Everything was done in accordance with Singapore Ministry's Directive of Health. She has really streamlined the work in her hospital, has taken the lead as the head of the department. She's shown the way, so I respect her, and she's a good friend, but then I was hoping that she could voice her opinion. She couldn't join us today, only in person, but then her video basically expresses very similar things that all of us have done, or all of you have done in all your hospitals. But she set the benchmark for us, and we followed suit. So that was the good thing. And they published a paper, one of the first few papers that came talk about how urologists can actually help. So just going to let this video go through. I hope you can see the video there, which is playing. I guess there's no volume in that, but basically the video is self-explanatory. And this is exactly how it is practically done. We've been trained. We had initially slides sent over to show us how it's done. And then we also had a bit of training on mannequins, but it was just a short-lived euphoria because we had to jump in as the caseload went up. So these shelters are put up now, and we have similar concepts in our hospital. And yeah, this was the day which defined Singapore's COVID situation. 23rd was suddenly from hardly about 100, 200 cases, we jumped a big number, and it's been unfortunately increasing to almost 12,000 cases today.
I guess your screen is froze. Yeah, I mean, it's frozen. Yeah. Okay, fine.
I don't know. I'm so sorry, but could you see the video so far?
Yes, now, yeah. No,
okay. Can you see it now?
Yes, we can on the right side of the screen. Yes. Yeah.
Okay. Apologies for this. I don't know why there's been a technical glitch. I guess you can't hear. Is that correct? But you can see the video.
Yeah. Earlier, even the video was actually in a, I mean, the screen was frozen and we couldn't see much, but audio, okay. Yes, we don't get the audio. So
I was just explaining that what all has Sharon done. And this is just the practical experience that goes on in the center. And this is, yeah, I think basically we've been doing this as well in shifts. It's not been easy for our nurses. For most of my urology staff nurses, one by one, have actually been deputed either in the ward or other places. They've all had to go and share responsibilities. They go through this process day in and day out. It's not so easy. The problem with any country is as long as the caseload is increasing, everybody has to participate, everybody has to volunteer, and it gets tiring. So you need everybody's help all the time. So this is, this video basically shows what all goes in the infectious disease center. Hats off to these people because they are doing this 24/7. We do them in shifts and we still can get home, but we do share urology responsibilities at the same time. And she's showing you practically what we have to do. It's not just exactly after that, you got to wipe down all the equipment after every patient. That's not an easy job either. It takes some effort.
अभी रुक जाओ बेटा, नहीं बेटा अभी तुम लोग जाओ, मेरा बस खत्म होने वाला है।
And we do still nasal swabbing, so we do it from each nostril. It's not the most comfortable thing to go through for a patient, but it's essential. So the slightest of symptoms now we swab them because our foreign workers working in Singapore, the numbers have been increasing. We've actually started now moving to the dormitories. So we've set up these mini units in the dormitories where people go and screen. So like I was saying that this Monday was a terrible Monday. I think she sort of expresses what happens when the workload goes up. So I'm going to continue the slideshow from here. Just let me know if you guys can't see because I'm just surprised why it's happening. Okay, so I've come to my hospital and this is my hospital. And so this is the outpatient block and it connects to the inpatient block and the surgical block. And then the last part over here is actually a community hospital. So what we're trying to do is somewhere here, we're trying to restrict the movement of patients. And we are trying, the outpatient block, obviously the workload has become less. We're doing exactly what you guys are doing. And we are trying to put all the COVID infected patients over here in designated wards. Like you said, Jeremy, because even there, I think it's important to isolate them. In Spain, the cleaning measures that are happening, very similar cleaning measures. So we want to restrict the COVID positive space to one block. And fortunately, the community hospital, we're trying to isolate the non-COVID positive patients who do need medical treatment in that block. Not an easy job, but we are quite effectively moving that towards that slowly day by day. And so this is basically what happens in our hospital. We started off with the necessary precautions when we do. We actually wear N95 even when we take rounds now, because quite a few patients are admitted in the hospital who are N95 positive. And this is me today. It's nice to wear all this protective gear, but believe me, at the end of it, you look sick, you feel sick, you look hassled. So this is the timeline to show how things have changed. This is part of our publication we just submitted. But elective OT and outpatient load is reduced from 30%, this was as of 17th of April. And from then to now, I would say it's just about 10%. Most of it is being through through all the social, through other ways like telecommunication. We are now catering a lot to the clusters and dormitory. That has been our prime focus to get things in control. And we get rostered, and suddenly you get a message or you get your email. So you look at when are you rostered, where are you rostered, is it emergency or is it the fever tent? We've given our names up and everybody's pitching in from different departments. It doesn't matter who you are. Some things in our hospital is we have this little robot which carries things around. This is now actually very effectively being used for the COVID positive wards. So that's something which is in our hospital. Luckily, we have that option. And this is in our OT. The anesthetists actually have this fantastic box. So today's patients, when we had to do, one of them was COVID positive when I was operating in the morning. They actually intubate in this box, which sort of protects them. And even the nurses can put a hand through this. So a small innovation, but a lot like you were showing, Deepak, sometimes you need to just adapt to the circumstances. The unique thing that I found in our hospital is this. And suddenly I found on my trolley, everything is plastic, everything is disposable. It used to be metal earlier, but everything is disposable. And I maybe that's a good way, a good thing to have. Fortunately, we don't have COVID in urine, but still, you never know. And before we move on to share everybody's take-home messages, I just wanted to show this slide. If we are worried that it won't affect us, it's something to consider. Nupur and Jag, they are physicians in US, and they are professors. He's a cardiologist, and she's working with the multimyeloma. She's a professor in that, and she's she got positive, asymptomatic. He got positive, symptomatic. And when I was sharing with her separately, but then she shared it on a public tweet as well. And it was terrible. And what I can make out from her tweets were that it was not only personally taxing, it was also professionally extremely taxing. So I think the problem is we don't know when or who COVID is going to hit. So it's very important, like Jeremy said, that we have to mask up. Masking is not excusable at all. Social distancing is probably also equally important. So I'll just exit here, and let me share the take-home messages from the other speakers. We'll start with Dr. Loeb. Would you like to share your take-home messages to us? Dr. Loeb? I hope people can hear me. There was a bit of a faux pas on all the equipment. Okay, we can see your screen well.
Great. So in terms of the future here, I think we're just going to have a huge surge in patient demand. I have had a lot of US urologists telling me that they don't expect to have any summer vacation due to long waiting lists. Also, it'll just be interesting to see how telehealth fits in now once people are able to start coming back in. How it'll be used. Will it replace some clinics? Will you do it on other days? So we'll see. There's also going to be a resurgence of all the clinical trials and other research activities. Sadly, I think this is just going to have a really big impact on research for many other health conditions because things have just come to a grinding halt around the world. So that's just one of the many aspects of the toll that this will have on the scientific community. And hopefully we'll have some greater coordination of response, having learned through this process. So my advice to viewers are to establish a telehealth program if it's possible in your local context. I think this is the future and can be useful to a lot of different populations, whether it's rural individuals or even in urban settings where commuting is a difficult issue. Also, it reduces the carbon footprint by eliminating unnecessary transportation and just makes the provision of healthcare a lot more efficient. I suggest keeping your own personal protective equipment for future use with all the shortages. If we know that we're on the front lines, we need to be prepared. I've been helping my uncle convert his sign business to creating face shields and have been testing them and prototyping them. So hopefully, thankfully to the generosity of our community and everyone coming together, whether it's, clothing designers making masks, I think there is the possibility to get a lot more supplies in a cheap way because anything is better than nothing. And of course, just taking advantage of all these new online resources that have been created for learning. And then, finally, I think that it's important to just consider what is driving all of these infections that we're seeing, whether it's swine flu, SARS, this current epidemic. The vast majority of infectious conditions, actually more than 3/4, come from animals to humans due to deforestation, which is largely driven by cattle farming. In fact, 80% of the Amazon deforestation, it was simply for livestock, for human consumption. And this is also the reason for a lot of antibiotic resistance is factory farms with animals having a lot of antibiotics in the food. So bottom line is I think that, we need to think more about prevention and how to be a more sustainable community. I'm sure many of you have seen these aerial views of our countries with so much less pollution and these amazing pictures with dolphins in the waterways in Italy and things like that. So hopefully, we can be a bit more thoughtful in the future as to, how to treat the world better.
Definitely.
And lastly, these are some resource pages that I think can be useful, both the AUA and EAU. They've put together a lot of resources, tips for telemedicine, help with surgical prioritization, etc. So I would recommend any of the viewers to look to these areas.
Fantastic. Thank you so much. And Daniel, would you like to tell us your take-home messages?
Sure. Let me share. All right. So here's my personal advice. I think first, do not underestimate the virus. Even if it is not airborne, it is highly contagious. So I got the virus and I was at home for 3 weeks. I barely had any symptoms, but that's my advice for everyone. You don't know who's got the virus because you can be contagious even when you have no symptoms. Also, patients can have urological emergency and COVID-19 because sometimes we see a patient with fever and the CT scan shows a stone in the ureter and we say, oh, right, the fever is coming from there. So they can have both things. We all have to remain vigilant. Another personal advice, I think, is try not to disseminate preprints, low quality evidence, in vitro studies, bad news focusing on deaths, because even when a lot of people is dying from this disease, they're mostly elderly and fragile patients, and they can just lead to anxiety, stress, the psychological impact in the lay people, in the lay population, and in healthcare professionals. It's really important. So maybe we should not disseminate stuff that only creates anxiety, stress, and empty hopes in treatments and vaccines that I don't think a vaccine is coming anytime soon. So I think the psychological impact may be even worse than the disease itself. So it is important trying not to disseminate anxiety and stress in population.
Yeah, that's true. Great. How about you, Dr. Cho? You still with us? Or has your patient necessitated you to go back? Dr. Cho? Okay. What about you, Jeremy?
Okay, I'll just say a few words as take-home messages. I think from our experience in Hong Kong, it really requires cooperation from the whole, the whole population to have protective measures in order to be effective. And I feel very strongly about it because at least in Hong Kong, everybody is really complying with the protective measures and seems we are doing quite well on that. And in many parts of the country where there's already an outbreak, certainly think COVID testing will definitely help reduce the risk of transmission, especially when you have to take care of these patients in the hospital. And Darren talked about prioritization of surgery, and many organizations, including EAU, has the Rapid Reaction Group having guidelines, recommendations on prioritization of urological services. I think these are things that we should take into account. From a urologist perspective, apart from respiratory type of transmission, there are always concerns about possible transmission via stool and also urine. I think this is a reasonable concern. I think there are recent papers finding viral RNA positivity in stools in about 60% of the cases. It can occur. as early as 2 days from symptom onset and can last up to more than 30 days. In urine, I think most people would think that it is usually negative, although we do have a few reports from China. If you take those cases into account, then it's about 5%. And one knows about the duration of viral shedding because we just do not have a serial testing type of results from those reports. But I think it's something that perhaps we should know as a urologist. So yeah, that's the key messages that I want to bring out. So I hope everybody can stay safe and please take care of yourself.
Thanks. Darren, how about you?
Okay, I got video. Just going to quickly share the screen. Not much extra to say. As I say, when it's all been said, then make sure that it's a fool who speaks next. So my take-home messages, we've done those ones. I think we're all talking about that, the non-COVID surge and reintroduce carefully. Unquestionably, it's been excellent that everybody has had one single purpose. It's made the team bigger, it's made the world smaller, and it has made red tape disappear. One of the things that has been difficult with the pace of change has been that the truth has changed moment to moment. And if you've got advice that is conflicting, that definitely adds to the confusion and the anxiety for staff and for patients. And working from big organisational websites, so Stacey's just mentioned the AUA, EAU, our BAUS one. We have NHS England. We've seen all of our organisations have different advice. So the College of Surgeons had different advice to the College of Anaesthetists, which was different to the what was being put out nationally, and that may have slowed us down slightly. Collaboration has always been the way to get things done. One of the ones that's been interesting, I love sport, and Formula One is my favourite. So it was amazing to see that Mercedes F1 collaborating with our amazing intensivists and anaesthetists from UCH to make CPAP ventilators, and just like the introduction of nursing in Spain or setting up shockwave services, this was all done almost in a matter of days. And certainly within a week. Any new product coming onto market, normally takes 5 years. And then, of course, the future is going to be some form of telemedicine. So I've seen one patient in real life in the last 5 weeks, and that was somebody who was coming up for a CT scan on the day. And I think that's going to be the main reason for seeing somebody in the hospital and at the same time. And I hope and expect that by using telemedicine more wisely, that we can streamline exactly which patients need to be seen in real life and which ones can be managed perfectly well on an iPad. The caveat for that is that we just have to be careful with our own time. That does not mean having consultations with people, almost like we're doing this webinar now, Saturday afternoon. For me, in a moment, I'm going to go and sit outside. It's sunny. I'm going to have a beer. And I expect that Stacey will want to have a coffee and some breakfast.
All right, thank you so much. Dr. Cho, you're back. I hope your patient is well. Just give us a few take-home messages from you.
My take-home message is just please stay safe with quarantine, everyday quarantine.
Everyday quarantine. Yeah, I mean, I think that is definitely important. Deepak, how about you?
Okay, it's okay. Just
I guess if you have to see the take-home messages, it's pretty much all said from Professor Stacey to Dr. Darren and Daniel. They've all covered it all up there. We know one thing, that this coronavirus is here to stay. It's not going anywhere. So we need to adapt to the changes that are required. And we need to protect ourselves, our family, our colleagues, and the community around us. And we need to learn to live with it. There's no other way. And if I have to summarize the whole thing as to what all of our panelists have to say, And our Prime Minister also says the vowels like A, E, I, O, U to adaptability, efficiency, inclusivity, opportunity, and universalism. If you have to put these words, all of these have been explained by our colleagues in various different ways, and that's the only way forward. We need to win this fight, and then we'll win the future for sure. And that's it. That's from me. Thank you.
All right. So that was really nice to hear positive endings over there. I'm just going to invite Amit Kansal, Dr. Amit Kansal. Can you hear me?
Hi.
Hi. So Amit is our hospital's intensivist. He is the senior consultant who's been managing very well all our patients who come to ICU. And Amit, you know, the reason I brought you on in the end is because I just wanted to show off that, you know, urologists do some work. But no, truthfully speaking, Amit, thank you for patiently waiting. And I know that you have a subspecialty in pandemic care. So how has it been for you in the ICU in this period? Just, you know, share your thoughts and tell us about your teams. How do you guys work? How many of you work together for one patient? How's the distribution? Share with us about your ideas in about 5-6 minutes. It'll be really nice to hear.
Thanks for the opportunity, Vineet, and I hope next 5-6 minutes will be useful for the urology colleagues. So I guess a lot of this has been covered already, and I feel one thing, there are a couple of things. There's a government response. There is a pandemic preparedness at that level. Then there is a hospital facilities and the staff management. And there is some specific treatment or supportive care for the patients. I think we are very clear that unfortunately we don't have, we can't do much once the patients have already become that unwell. It's usual, good quality supportive care, which starts from ED, which goes on to wards, which is done in the IC care. One thing is sure that we know from all the publications from the last couple of months, COVID is not a short journey. It's a long journey for the patients. Patients who come to us, they stay with us for 2 to 3 weeks. Thereafter, they stay in hospital for 2 to 3 weeks. And from our experience, we know that they move a little and they will desaturate. So first up, there is an initial very high mortality that we saw in, unfortunately, in Europe and US, which is in the first kind of 7 to 10 day period. Maybe there were comorbidities, maybe there were elderly people. Then there is a second phase of mortality, which will come after a few weeks to months of the stay. Nobody dies of ARDS. People die with ARDS. So they will have the usual nosocomial infection, they will have the usual stuff. So that will happen. And then obviously we're all worried about the experience. So how we have organized our staffing. So definitely it's overwhelming to see how much support we are giving each other. In that sense, the support which comes from the surgical side, from the subspecialty side. They've been like helping with ED, they've been helping in community with the swabs, they'll be helping in ICU. There's a plan that, so I look after some part of training for the pandemic preparedness. So we've been doing some 2 to 4 hour kind of induction sessions for our surgical colleagues who may need to be inducted in ICU. And the focus is to showcase how good we are with staff safety and how good our facilities are. I don't talk about the treatment which we get on. Unfortunately, it's nothing. So staffing wise at this stage, again, we start with the best case scenario. So I can say that fortunately our numbers are small enough at this stage where we can follow our peacetime staffing more or less. If anything, maybe a little more buffer there right now. Because everybody's leave is canceled, so everybody's here. So you can imagine that we have a planning for a certain number of leaves to be taken every now and then, and now everybody's there, and then we have reinforcements from other departments. So we are actually pretty rich right now in that sense.
Yeah, you look fresh on the seminar today.
But yes, we know that exponential rise can really make things really stressful very, very soon. And we have seen with some of our colleagues and we've heard their experiences. So at this stage, the planning is that, so we have almost peacetime, but then yes, there are plans in place how we will thin out our workforce, how we will accommodate more number of beds in more physical areas, and how we will in out the teams. Again, from ICU perspective, we have a plan that we'll always have a intensive care leadership from the nursing, medical, and allied health. So even if our colleagues are deployed there, they will not be left on their own. They will be supported in some way. And there was a question raised how a urologist can help or a subspecialty can help in a ED ICU environment. I believe like a lot of that you have already seen and we have discussed. And I would add one more thing. Actually, you don't want anybody to tube these patients. Like, you know, the first one day when they get the tube and the line, that's it, that's done. Now this patient will not need any more tube or any more line for the next foreseeable many weeks probably. So actually the battle starts after that 1 or 2 days. So 1 or 2 days yet, it looks hot and sexy, it's ABC, you do that, and that's kind of considered reasonably challenging, but I believe the challenge starts after that. So now I have a patient who is almost day 20, actually 2 of them, day 20 in ICU, and yeah, they don't even have a cannula probably because they are so low key, but they are both on the ventilators. There is no way I can get them off the ventilator. And what they need now is a very good nursing care, very good medical care, attention to nutrition, attention to their psychological health, and so on. And that is where we need a lot of manpower, and we need a lot of compassionate clinicians who can help us with that.
You do a lot of pep talking to your nurses there?
Actually, again, fortunately, everybody's so driven. Maybe we are early in the phase, or maybe we were never overwhelmed.
Okay.
But I feel everybody's training involves that part that we are here to do something good. And I believe it's not just adrenaline rush. I think it's just the way people are, the way we are. It's a natural selection that people are really, really switched on. And
maybe they like you too. So, they're happy to work for you. And I know the head of the department of the ICU, she's excellent, and you do a fantastic work. So it's good to know that you have a very, what I can get across from you is a very relaxed ICU, willing and ready and prepared. So that comes forth as very good. And I think that's important in a lot of centers who are getting ready, that the ICU support. We give them a lot of support, but the ICU also is all set to take on whatever is the preparedness that goes with it.
And I guess one important part of that is staff safety. You cannot let your guard down at any level. And we have already discussed, the COVID problem is here to stay. If not COVID, in few years' time, we'll have something else. And I think the lessons we learn now, actually, we've seen that SARS didn't hit Hong Kong that fortunately. We had our lessons learned from that time. And hopefully, like the lessons that we take from here, staff safety, because when one of us goes down as a quarantine, suddenly you lose a whole big team. And we have seen that in occasionally in other departments as well, which can happen because patients unexpectedly turn positive. So that can happen. And yeah, so keep the guard up. And I guess it's even more important for frontline people like you when you go back to clinics. It's going to be really, really important that way.
Yeah, we'll keep the faith, and thank you. And I didn't think the presentations will go for so long, but then it was very interesting, so I couldn't. I'm going to just share my final slides. I don't know. Again, I hope we can see them. Can we? Okay. So, like I was telling you, this is the husband-wife couple, which I take an example and say it could happen to any of us. And God willingly, both of them are doing well. But I think the most important part today is, like Amit said, we don't know how long this problem is. Like Darren or Dr. Loeb has mentioned, it requires the entire community and us to come together to really work hand in glove. We pray for the world, and hopefully all of us get together and this virus, we beat it, because this statistic is changing every minute as we speak, and I don't like that. The number of deaths is what affects us, affects the social well-being in the society. Yeah, we are praying to God, and actually He's already given you the answers. He's given us masks, He's given us sanitizers, He's told us stay at home, maintain social distance, and I wish people listen, because if they do that, I'm sure we'll be able to fight this battle and get over it at the earliest. This is my niece. She sent me this today, and I think it's her way and my way of thanking all of you and thanking all the listeners who've been with us, who've been patient enough. This is the first of its kind we tried. I had some technical glitches, so pardon me for that. And thank you all for making time and coming onto the show and being on the webinar. Definitely a big thanks to Nitish, without whom I don't think I would have been able to even suggest this possibility. So thank you so much, Nitish. Do we have questions that we need to answer, or has it been a really long time already?
Yes, I guess we're well past 7:45, yeah, 2 hours.
Right. So I think most of the questions might have been answered. With that, maybe let's just hope that all the countries heal up fast. And so, you know, make sure that you catheterize well wherever you are and continue to do the great job. Thank you so much, Professor Stacey. Thank you so much, Professor Darren and Jeremy, Dr. Cho, Deepak, and Daniel. Thank you so much. And Amit, a big thanks to you too. We'll say bye over here.
Thank you, Vinit, for organizing.
It's like saying goodbye at a party. You've just got to wait for somebody to make the first move and go. Vinit, thank you for coordinating it. To everybody, for you guys who are further west, go and have some nice dinner. I'm going to go and sit in my garden. Stacey, who's earlier in the morning, have a good rest of the day. Everybody take care. Thanks for inviting me to take part.
All right. Have a good day.
Thank you.
And
Bye.
All right. Bye-bye.